Okay, now it's time to invite, I deem it as my privilege to invite Dr. Arup Chakraborty for the next talk. So he's a celebrity ophthalmologist. I'm a big fan of myself, and he's a master speaker, very deft surgeon. He has probably taught countless people to acquire surgical ophthalmological skills. He's a very articulate orator because the topic that's given to him actually requires one such man, and probably a quintessential part of Indian ophthalmology academia for last 3-4 decades. You must have heard of a lot of names in the named IOL formulae. Okay, Dr. Chakraborty has probably been rubbing shoulders with all those legendary ophthalmologists because he is a man who is most known in the international fora, as he represents Indian ophthalmology at the international level. So we have Dr. Arup Chakraborty from Trivandrum, from Chakrabarti Eye Care Center, who will be talking about probably the most important topic. I told you refraction is important for exams and practice. IOL formulae, it's going to be for today and tomorrow. That is the most important thing. You will be doing cataract surgeries. We have scaled up the quality, we have increased the aspirations of the patients, and we are probably, the refractive surgery has married cataract surgery now. So you need to have a very clear understanding of what IOL formula actually, how it makes sense. It's so difficult. Many a times you must have given seminars in your classrooms, but nobody has understood. Somebody who knows more probably can only simplify, can tell less. So here Dr. Arup will be talking about the very relevant, very contemporary, very important topic of biometry and IOL power calculation. Sir, in the next 15 minutes, sir, please do cover it.
Good morning, friends. At the outset, I'd like to thank Santosh for alerting a topic to me which is some sort of a passion for me. And thank you, Krishna Prasad, for the very kind introduction. I'm just going to give you a brief overview of intraocular lens power calculation, target refraction, etc. Because in the limited time available, this is what I can do to the best of my ability. I would also request you to enroll for the skill transfer courses that are going on, where you will have hands-on experience and on the various biometric devices. Because I'm not going to talk to you about any of these hardcore aspect, the machine aspect of my presentation, or how to handle them. So you better attend a skill transfer course for that. Nothing financial, though I'll be talking about a couple of devices here. Now I'll start off with a real life clinical scenario. This happened to me. An elderly man, I had done a standard clear corneal temporal phaco 2.4 millimeter monofocal IOL. Right eye, a patient had 6.6 and N6 without glasses. He was actually, it is pseudo accommodation. And when I operated on the second eye and the patient returned for glass prescription, he was very, very dissatisfied. This is so-called refractive surprise. Actually, it is such a good refractive outcome. With minus 0.75, he reached 6.6, and he requires only 2 diopter to get N6. So even without having a refractive surprise, you could have patients blaming you and feeling very dissatisfied, because maybe in this case proper counseling was not given. He was not told that it is just a monofocal intraocular lens, and you need presbyopic, you'll have pseudophakic presbyopia, and you'll need correction for that. So this is what had happened. The fellow was operated a long time back. So that time the pupil wasn't very small, and it was not a very hard cataract. But when he operated on the left eye, pupil had become small, senile meiosis, and it was a hard cataract. I had to use iris hooks. And as a result of that, you had a pupil which was traumatized, and perhaps that was responsible for it. So you must realize that today cataract surgery is a refractive procedure. We want to hit the target refraction in each and every patient that we operate upon. And for most of the patients, the target refraction is plano 6.6. This is the holy grail. So this is where we intend to arrive in our journey, our destination, our goal. So where are we today? We need to assess where we are today so that we can chart out a journey. Before I go further, I would just take a small quiz from the postgraduates here. Can anybody identify this gentleman that you see on the screen? The postgraduates? Sir Harold Ridley? Why his name is written in letters of gold in International Ophthalmology? Yeah, he implanted the first intraocular lens, way back in 29 November 1949. Now, why I am talking about him? Because his first two cases had a refractive error of -21 and -15 diopter. All right. And subsequently, he incorporated a lot of changes, and still the refractive surprise did not go away. His median post-op refractive error in his this second cycle, which was audited, was -2.25 diopter. Again, if you have this kind of refractive outcome for your patients today, you have to stop your practice. No patient is going to come to you. So what are the target? What are we aiming for? See, if you look at the guidelines by the Royal College of Ophthalmologists, the cataract surgery guidelines, 85% of your post-op patients should land within 1 diopter of target refraction. But I think we definitely can do better. And whatever I'm telling you is from my personal experience, but I need to give you evidence. So this was an article published in JCR just 2 years back, where it was found that using all the modern formulas, a prediction error of plus minus 0.5 diopter, that is post-operative period, you are able to land a patient within this range, between 88 to 90.67% of the patient, which is a phenomenal number. And with the older formulas also, the results were pretty good. So this is where we are heading for. Now, for us to achieve the target refraction, it goes without saying that the surgery has to be very safe, no scope for any complication. You need to take care of the astigmatism, and toric IOL is what we do today to take care of corneal astigmatism. Use a premium intraocular lens and a multifocal lens, any presbyopic correcting lens. I'm not going to talk about this. I'm sure there are other speakers dealing with these topics in the subsequent sessions. But what I'm going to talk to you is about how do you increase the refractive accuracy for IOL power calculation. Now, before I start off my talk, I would like to pay tributes to these gurus of intraocular lens power. Over the years, they had the publications, their presentations, and we have benefited a great deal from their discourses. So I would like to acknowledge the role in my developing my presentation. So when I was a postgraduate student, and a couple of years after that also, I used to think that IOL power calculation is just one small tick that you make on the preoperative checklist. But then I soon realized that it is the IOL power calculation is an experience altogether. It spans the preoperative period. Bulk of the action takes place in the preoperative period. And it also, there are events intraoperatively or postoperatively when you check the patient's vision and when you fine-tune a surgery, that also plays a very important role. So you must not think that it is just a one-off incident in the patient's lifespan. So preoperatively, I would like to know why the patient's vision is reduced, because it may affect my biometry. Does the patient have a very advanced cataract? Does the patient have a posterior staphyloma? Does the patient have amblyopia or fixation losses? I would also look at the ocular surface. And over the last couple of years, we have realized that an abnormal ocular surface can adversely impact the corneal measurements. The corneal measurements will be off what it actually is. So whether you do a spherical calculation for a toric IOL, you will be calculating the wrong axis. If you think calculating for a monofocal or a multifocal IOL, you'll be calculating a wrong power. So make sure that ocular surface is properly examined preoperatively before you start your biometry. And if you find any defect in the ocular surface, any ocular surface disease, the ocular surface has to be optimized by proper therapy. And once the patient has ocular surface optimized, you do a series of biometric evaluation and accept 2 consecutive repeatable values. So it takes about 6 to 8 weeks for us to get a very stable keratometry for these patients. Nil touch biometry cannot be overemphasized. We need to perform all these investigations on a virgin cornea, not on a cornea which has had a lot of insults with topical medications like anesthetic drops, mydriatic drops, or cycloplegic drops. So no prior contact procedure. Now sometimes what happens is a patient gets ready for cataract surgery at the end of the day after all the evaluations are over, and by that time the cornea is really hazy, and it is important for us to call the patients back on a different day with a virgin cornea and repeat the investigations. So once you've ruled out the ocular surface issues, patient counseling is very important because not all patients want to read plano 6/6. Some of them want to read without glasses, without glasses, intermediate distance or near distance. So all these things have to be ascertained before you set up your target refraction. I always believe in performing biometry using at least 2 devices and use more than one formula for IOL calculations. Now, regarding biometry, what are the parameters that you're going to take? You're going to measure the axial length, the K readings, anterior chamber depth, the white to white diameter, and lens thickness. Most of the formulas require these elements. So for the formulas to give you correct prediction, you have to ensure that what you measure is absolutely accurate. So cornea can be measured in various ways. You could use a manual keratometer or an auto keratometer. I used to do it earlier, and now I don't do them. Then must realize that optical biometry has taken over. I mean, we have started resorting to optical biometry, which is a multifunction device, and it also measures the cornea. And then if you're going for a multifocal IOL or a toric lens, it is a good idea to learn more about the cornea. Rashmi has spoken so well about topography and other things, and eye trace. So these are the things that I routinely do for all my preoperative patients. If the patient is wearing a contact lens, ensure that the patient is off the contact lens. If it is a hard contact lens, minimum of 2 weeks before biometry, the patient should be off the contact lens. Coming to the measurement of the axial length, all of us have been doing ultrasonic biometry for a long time, the scan biometry. So I just can't say that it is obsolete in our country. We are in a developing world. So we definitely use A-scan, but I would suggest that you go for an immersion A-scan for your patients and not the contact apprehension. Because we have learned over the years, and there are a lot of publications supporting it, that contact application, contact technique or apprehension technique is less accurate, and it usually results in a shorter axial length, by 0.25 to 0.33 millimeter. This problem accuracy issues can be sorted out if you use an immersion A-scan. Now, optical biometry is what we do routinely to measure the axial length, and we have come a long way. But more than two decades earlier, IOL Master 500 was launched in the market, and it gives a very accurate axial length determination. And so there are always some naysayers. They say that you don't have to invest for optical biometry because you get good results with ultrasound biometry. But then I would again go back to evidence. This is courtesy Dr. Wolfgang Heigis. He was a mathematician, he's not an ophthalmologist. So these 11 publications clearly show the red bars that you see are IOL Master 500, optical biometry. So accuracy level was much higher compared to when immersion biometry was done. So whenever you have an opportunity, please use an optical biometer, particularly in situations where a patient has a posterior staphyloma, or it is a post-vitrectomy eye with silicone oil inside the anterior in the posterior segment. So these are the cases where you need to get a optical biometry done. There have been new advances. The swept source OCT devices have come up. So these devices have taken care of some of the limitations or drawbacks of the earlier optical biometers, which were using the older design. So the penetration is better. So these devices enable you to get the axial length in situations where the nucleus is very dense, or even if there's a thick posterior subcapsular cataract. 2 more devices are being launched in the market, Antarian from Heidelberg and iStat 900. These are basically OCT devices which have been added to the optical biometer. I'll not be talking much details. But please remember, just because you have an optical biometer, it is not the end of the problem. It's not a magic wand that, you put the patient on optical biometer and you get a perfect, accurate axial length. You have to ensure that the validation guidelines are followed. In your practice, when you start off, it is important that you do all your biometries. And as your practice grows and number of patients improve, then you may delegate the responsibility to your optometrists or technicians, but you have to be in charge. You should know the latest, what is happening, what are the possible mistakes that can happen. And there are validation guidelines. For example, there are certain guidelines that come up. This dish has to be stuck on the biometry wall, room wall. And those values, suspicious values, dubious values have to be deleted, and you have to take repeat measurements. So now I have already spoken about the patient counseling that is important. The intraoperatively, what is so important about it? Because it is again the expected lens position, wherever the lens is going to rest. So today we have to do we will do a cataract surgery through a 2.4 to 2.8 millimeter clear corneal temporal incision, make a rexus which is not more than 5 to 5.5 millimeter in size, ensure that the lens stays exactly within the capsular bag for your target refraction for you to really materialize your target refraction. Post-operative period is the moment of truth. This is where you find out whether you have landed on the target or there has been any deviation from the target. And then subsequently you can fine-tune your biometric evaluation and IOL formula utilization. Okay, now moving on to the formula. So I have just told you that you need to get very, very pure data, biometric values, and then they have to be put in the formulas. Most of the time these formulas are already there in the software of the biometry machine device, whether it is an ultrasound device or whether it is an optical biometer. So please do not follow this generational classification of formulas. It goes up to generation 1, generation 7. This is so chaotic. This doesn't have any method in it. And so we tend to follow this new classification system, which is based on the method of calculating IOL power and the data they use for these calculations. Historical refraction based. When I was a PG student, my teachers used to use 18 diopter lens for all patients. That is again obsolete. That should not be done. Regression formulas, SRK, SRK2 again should not be used, though unfortunately SRK2 formula still happens to be present in many of these ultrasound biometry devices. Well, let's see, please remember that for eyes within the normal axial length range, most of the formulas give you pretty good results, but problems happen when you are dealing with extremes in the cornea, steep cornea, flat cornea, long axial length, short axial length, thick lens or thin or not a very thick lens, etc., etc. So Vergence formulas, they still hold sway, Holiday 1, SRK-T, Hoffa-Q, Holiday 2. Please remember that these formulas are more than 20, 30 years old. They're the previous millennium. The phones that you're using to take the pictures, so it's okay, you can continue to take the pictures, but these are purchased just a few years back. We are not using cell phones which are purchased in the previous millennium. All right, so why do we continue to use, please continue, I'm not stopping you, but this is just to tell you that, all the contents will be captured. See, there is a video which is capturing the screen, and this will be uploaded in the AS Editor Proceedings website, and you can continue. There's no harm in continuing your pictures. So what I was trying to tell you, just an example that we don't use old cell phones, we don't use old cameras, we don't use old laptops, nothing, cards. So these are the current formulas, which are definitely giving us very good results. Barrett Universal 2 is my go-to formula. Hill RBF is a very nice formula. And then new kids on the block, the Kane formula, Evo formula, they have come up. Barrett Universal 2 is fortunately available free in this particular website. This is a whole calculation suite. All your IOL requirements, a patient, a normal cornea or a post-refractive surgery cornea, toric IOL or a non-toric IOL, and a patient who has refractive surprise and you want to perform an IOL exchange, maybe just 2-3 minutes IOL exchange or piggyback lens. So this particular formula will take care of all your IOL power requirements. And this fortunately can also be used for immersion A scan, but only thing is when you're using an immersion A scan value, biometric value, please ensure that you use an appropriate A constant. Any intraocular lens will have two constants. One is for the optical biometry, other is for the ultrasonic biometry. So you have to be very careful about selection of the IOL constant, lens constant. Other formula is the Hill RBF formula. This is again free at the ASCRS site. This particular formula is a artificial intelligence based formula, and so version 3 was just released a couple of months back, and it is also pretty accurate. I use multiple formulas for any given case. For example, now this was an IOL, this is a patient with an ICL, high myopia, ICL, and cataract, so I had to remove the ICL and do cataract surgery. So my Barrett gave me a calculation IOL power of 2 diopter. All the other previous generation formulas gave me an IOL power of 3 diopters. So I used a 3 diopter lens, and ultimately I was pretty happy with the eventual outcome. Lens constant is very important, lens constant optimization, and if you're using Hill RBF, if you're using the Barrett formula, most of these online formulas, they have lens constants already optimized already within the formula. All right, so today individually a constant, lens constant optimization may not be required because these are already available, but if it is a new lens, then I would start off using a manufacturer's A constant, which is put on the lens box. So friends, in summary, as far as IOL part calculation is concerned, please remember, you are the boss. If something goes wrong, ultimately you are held responsible, so it is your responsibility to ensure that all precautions have been taken and a proper workup has been done. Use appropriate measurement devices depending upon the setup that you practice. Use validated measurements. Wrong measurements, doubtful measurements should be deleted and eye should be remeasured. Use the newer formulas. Work with properly optimized lens constants. Adapt to new technologies as they present instead of harping on the same theme that technology, new technology is just a benefit for the vendors. Most of the time it is not that, so you need to be proactive and adopt and absorb the new technologies as and when they present, and strive to use all available resources to the best advantage. Thank you so much for your kind attention. I think I have just done a minuscule. Please attend the skill transfer courses where you will have a hands-on experience on all these biometric devices and more about IOL part calculation perhaps in those halls. Thank you so much. How many are postgraduate students here? Can I see a show of hands? It's a good number, isn't it? Thank you.
Thank you, sir, for a very eloquent, lecture on a very important topic. Actually, I think it's not just postgraduate. Everybody has something to learn from this talk because this is never expanding, and somebody like only Dr. Arup can do justice. Thank you very much once again.